Hi, my name is Dr. Sukriti Bantia, and I'm a fellow at Ascension Providence Hospital and a Cardio Nerds Fit Ambassador. I'm excited to attend the AHA Scientific Sessions 2024 from November 16th to 18th in Chicago, with Early Career Day on November 15th. This year, AHA celebrates its 100th birthday with over 500 sessions, including cutting-edge science and the release of the new 2024 Scientific Guideline. Cardio Nerds Conference scholars will be there too, so make sure to register at scientificsessions.org.
And when registering, be sure to use the code NERDS, because if you're among the first 20 to sign up, you'll receive a free 1-year AHA professional membership. And with that, let's get to the show.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey Cardio Nerds family, this is Amit. On behalf of all of us at Cardio Nerds, we are thrilled to bring to you our Decipher the Guideline series for the 2022 AHA ACC HFSA Guideline for the Management of Heart Failure. Get ready for short and bite-sized, high-impact, clinical vignette-based questions designed to highlight core concepts based on cutting-edge evidence that are relevant to your practice. The cases we use are hypothetical and created for educational purposes only. This series was developed by the Cardio Nerds and created in collaboration with the American Heart Association and the Heart Failure Society of America. It was created by 30 trainees spanning college student through advanced fellows, with mentorship from Dr. Anu Lala, Dr. Robert Menz, and Dr. Nancy Schweitzer. We thank Dr. Judy Bazanson and Dr. Elliot Antman for their guidance along the way. So friends, join us as we get to learn about the heart failure guidelines and beyond from 16 leading faculty experts. And now, let's get nerdy.
The following question refers to Section 7.4 of the 2022 AHA ACC HFSA Guideline for the Management of Heart Failure. The question is asked by Cardio Nerds intern Akiva Rosenzweig, answered first by Cardio Nerds Fit Ambassador Dr. Jenna Sporonsky, and then by our expert faculty, Dr. Clyde Yancy. Dr. Yancy is Professor of Medicine and Medical Social Sciences, Chief of Cardiology, and Vice Dean for Diversity and Inclusion at Northwestern University, and a member of the AHA ACC HFSA Heart Failure Guideline Writing Committee. Thank you so much for joining us, Dr. Yancy. We're excited to have you.
I'm delighted to be here. Thank you for the invitation. Let's get started.
Thanks, Jaya. Hey, Jenna, I could really use your help with this patient of mine with a recent MI and reduced ejection fraction. I would love to hear your thoughts regarding next steps in management. He is Mr. S, an 80-year-old man with a history of hypertension, type 2 diabetes mellitus, and hypothyroidism, who had an anterior myocardial infarction treated with a drug-eluting stent to the left anterior descending artery 45 days ago. His course was complicated by a new ejection fraction reduction to 30% and left bundle branch block with QRS duration of 152 milliseconds in normal sinus rhythm. He reports he is feeling well and is able to enjoy gardening without symptoms, though he experiences dyspnea while walking to his bedroom on the second floor of his house. Repeat echocardiogram shows persistent LVEF of 30% despite initiation of goal-directed medical therapy. What is the best next step in his management? A, monitor for LVEF improvement for a total of 60 days prior to further intervention. B, implantation of a dual chamber ICD. C, implantation of a CRTD. Or D, continue current management as device implantation is contraindicated given his advanced age.
Hey, Akiva, thank you so much for this question. I love it. And thank you so much for telling me about his interest in gardening. That's fabulous. Let's get started. So choice C is the correct answer here. Implantation of a CRTD is the next best step. In patients with non-ischemic dilated cardiomyopathy or ischemic heart disease that are at least 40 days out from post-MI with a left ventricular ejection fraction less than or equal to 35% and an NYHA class 2 or 3 symptoms on chronic GDMT, who have a reasonable expectation of meaningful survival for greater than 1 year, ICD therapy is recommended for primary prevention of sudden cardiac death to reduce total mortality. And this is a class 1 level of evidence A of recommendation. A transvenous ICD provides high economic value in this setting, particularly when a patient's risk of death from ventricular arrhythmia is deemed high and the risk of non-arrhythmic death is deemed low. In addition, for patients who have a LVEF less than or equal to 35% sinus rhythm, a left bundle branch block with a QRS duration greater than or equal to 150 milliseconds, and NYHA class 2, 3, or 4 symptoms on GDMT, CRT is indicated to reduce total mortality, reduce hospitalization, and improve symptoms and quality of life. Cardiac resynchronization therapy provides high economic value in this setting. Mr. S therefore meets criteria for both ICD and CRT. Choice A is incorrect. Choice A was monitor for LVEF improvement for a total of 60 days prior to intervention. All patients should be on maximally tolerated doses of GDMT prior to consideration of device implantation to allow for assessment of LVEF recovery. Patients who have experienced myocardial infarction should be reassessed after 40 days, not 60, after the event, and achieved maximally tolerated doses of GDMT. Choice B, or implantation of a dual chamber ICD, is incorrect. For patients in sinus rhythm with a left bundle branch morphology and a QRS duration greater than 150 milliseconds with an LVEF less than or equal to 35%, there were significant improvements in a 6-minute walk test performance, quality of life, NYHA classification, and LVEF after implantation of CRT. Mortality and hospitalizations were also found to be decreased in patients with CRTP and CRTD. Overall, CRT has been shown to have high economic value in these patients. It should be noted that CRT has the most benefit in patients with a wide QRS, which is greater than 150 milliseconds, left bundle branch morphology, and an LVEF less than or equal to 35%. The trials have showed a modest benefit in special populations. CRT has a class 2A recommendation in patients with an LVEF less than 35%, sinus rhythm, and NYHA class 2, 3, or 4 symptoms on GDMT with either a non-left bundle branch pattern with a QRS duration greater than or equal to 150 milliseconds, or a left bundle branch block with a QRS duration of 120 to 149 milliseconds. And then finally, choice D, which was continue current management as device implantation is contraindicated given his advanced age, as a reminder, an age of 80, is incorrect. If LVEF remains less than or equal to 35% in a patient with a life expectancy greater than 1 year, trials have shown that an ICD placement for primary prevention reduces sudden cardiac death and also has a high economic value. There's no indication that this patient has a life expectancy less than 1 year. So our main takeaway for this patient is that in patients who are 40 days post-MI on GDMT with an LVEF that remains less than or equal to 35%, ICD therapy for primary prevention is appropriate and cost-effective. For those with a left bundle branch block and a QRS greater than 150 milliseconds, the RTD is also appropriate and cost-effective. Dr. Yancy, these are the guidelines, but we would love to hear your thoughts on this patient and how you would further manage him.
So Jenna, Akiva, Jaya, Amit, Ahmed, all of you representing cardio nerds, this really is a fascinating case, and I applaud you for bringing this forward to your listeners. Let's think about what's in play. It's an 80-year-old gentleman. I hesitate to call him elderly as I get older, but an 80-year-old gentleman with a recent anterior wall myocardial infarction, status was placement of a drug-eluting stent with a residual ejection fraction of 30% and a left bundle branch block pattern, which is nearly present. Whew, that's a lot to say. On evidence-based therapy at 45 days, persistent LV dysfunction, and more importantly, a persistent left bundle branch block pattern. So let's think carefully about what are all the right things we need to do. Let's be very clear. With the left bundle branch block pattern, there is a strong indication for a device. Listen to my words carefully. I said device because we need to think more in depth about the approach to placing a device. What are the issues that are concerning? The issue that concerns us is that this patient is at high risk for sudden cardiac death. In ischemic etiology, shortly after myocardial infarction, this is a time span where we typically see more events. This is one reason why the use of a mineralocorticoid antagonist in this setting is so important. The studies demonstrating efficacy, mineralocorticoid antagonism, invariably demonstrate a reduction in sudden cardiac death events. That's a benefit that is rarely embraced as much as it should, but we would argue that this is a very important early intervention for someone post-MI. The second thing We know that the ICD attenuates the risk of death after myocardial infarction, but we also know that independently, CRTP, that's pacing alone, also attenuates the risk of death. How do we reconcile this? There's a further permutation that we have here. We know that in the European guidelines, the indication for an ICD in the non-ischemic model, that is, reduced ejection fraction heart failure, not attributable to coronary disease, has a recommendation of 2A, not a class recommendation 1, but 2A. May be considered, but not is indicated. There's a big difference between is indicated and may be considered. So think very carefully about that nuance. That's not trivial because it has everything to do with how we proceed with care, even with reimbursement. In this country, it's still a class 1 indication, but we should be aware that other parties that we respect interpret the same data set and say perhaps for the non-ischemic model, there is not as strong an indication. And some have argued that the same thing may be relevant when we're thinking about women at risk for sudden cardiac death events. Conversely, there's always been a signal, inexplicably so, that women may benefit greater from a CRT device, perhaps because their underlying disease substrate may incline more towards left bundle branch block patterns. That's never been resolved. And so there are some nuances when we think about device-based therapies. But here's another important concept. This patient is still symptomatic, as so nicely portrayed in the capsule summary that Jenna shared with us. There is a possibility of what we call the super responder. When we place CRT devices, in this case, I would agree that it should be CRT-D, but when we place these devices and we're able to successfully accomplish resynchronization and overcome the electrical remodeling that is the consequence of ventricular injury. The mechanical remodeling is why we use quadruple therapy, but the electrical remodeling is why we use CRT. Some patients have a dramatic response, and the subsequent measurement of ejection fraction is improved by greater than 10 points, and the improvement in symptoms may be as much as to an NYHA class 1 level of symptoms. This super responder class qualifies as that new group of patients we talk about with heart failure, known as heart failure with improved ejection fraction. This is one of the ways that occurs. We don't want to miss that opportunity to provide this restoration of quality of life and freedom of symptoms if by chance he ends up being a super responder. The other thing we need to understand is that whereas we previously thought about CRT as a requirement for a left ventricular lead, which is always challenging, meaning you have to place the lead in the coronary sinus and place it, if you will, on the epicardial surface, we now understand that if we are able to do His bundle pacing, we can accomplish the same thing. Waiting for the randomized trials to prove the efficacy of that. But suffice it to say for this conversation that there's more than one way to achieve cardiac resynchronization therapy. The other thing we need to understand, and this is a key aspect of the practice of medicine, it's great that all of you are so facile with the guidelines, but for every therapy that we've discussed, we need to know the benefits and the risk, medical therapies included. So what are the risks of CRT-D? Beyond the periprocedural risk of infection and bleeding, we need to understand that about 5 to 10% of the time, the effort fails. We're not able to actually effectuate resynchronization. Even beyond that, with successful capture of the left ventricle in the traditional model, by 6 months, some of those applications fail as well. And so this is not a perfect science. It's getting better and experience helps. But understand that there are some important considerations, and this is where a shared decision-making conversation is very important. The high bar is protect this patient from sudden cardiac death events. The hopeful bar is improve ventricular performance. But it's really important to have these very transparent conversations, a care team that involves the physician who is agnostic to any return from the procedure, the electrophysiologist, the caregiver, the family, to really appreciate why we're placing this device. It's extraordinary to talk to patients who've had devices placed and post-hoc say, what did you understand about having this device placed? The stories are so heterogeneous. It's pretty clear that at the time of a serious illness, like myocardial infarction and coming face-to-face with your mortality, patients don't always process information in the way that we would wish, and perhaps we don't always convey information in the way that we should. So we should take great care. These are not emergency procedures. We should allow patients to raise questions, study, raise more questions, and understand risk and benefits in a very clear way. This patient is 80 years old. That should not limit our application of evidence-based therapies, but it should force us to appreciate the patient's perspective. I've never been comfortable taking a patient and lobbying that patient to the point of saying yes for an intervention. I've always respected the patient's wishes. If the questions have been answered, if the right concerns have been expressed, it's sufficient to say we've had the conversation and we understand your preferences and go forward. It's so hard to put yourself in that person's shoes and know what they would want to have done. So the right answer to the question, CRTD without any hesitation. The right clinical decision might be a little bit different, particularly when you digest that there are some risks. There may be some episodes of inefficacy where the system just doesn't work, even if it's not a complication. And a patient may have their own preferences about how they wish to be treated. But this is a case where we really need to be doctors first, and then great practitioners of the guidelines.
Thank you so much, Dr. Yancy and Jenna. Wow, that was an illuminating answer. And the emphasis on understanding the nuances of device-based therapy and the importance of balancing anticipated benefits with expectable risks and the value of properly informed shared decision-making. Thank you for contextualizing the guidelines within a patient-centered approach.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.